Yes, we are going live now.
Okay.
Yes, we are going live now. Yes, we are going live now. Dr. Priyank, can you see the full screen now?
This is lymphatic system.
Okay, I will change. So, able to see now? Dr. Priyank, can you see the full screen now?
Your voice is again and again repeating.
Yeah, just
lymphatic system.
Yes, we are getting late. We will start now. Am I audible now?
Yes, yes.
Good evening and a warm welcome to all the participants for today's webinar. As a special webinar today, actually, organized by EXRX India's organization. The topic is, let's talk about lymphedema. So, lymphedema and physiotherapy management on the occasion of observing World Lymphedema Day. Also, I take this opportunity to wish all the female participants a happy Women's Day, though it's a little late. This lymphedema awareness special webinar will be taken by Dr. Priyank Jain, who completed his UG in Gwalior and worked at Indoor Apollo. I take this opportunity to wish all the female participants a happy Women Hospital from 2010 to 2015. Also, he worked in Indian Institute of Head and Neck Oncology, and he started his own clinic, a center in Indore in 2014. Did his certification in lymphedema therapy from Tata Memorial Hospital, India, and also Academy of Lymphatic Studies, USA. Also, he completed Stillman Cancer Rehab Therapy course from New Zealand. Now, he joined Hamad Medical Corporation as a physiotherapist and lymphedema therapist in 2018 and presently working in HMC NCCCR, Doha, Qatar. I welcome Ms. Duna and Dr. Rupesh for the session, and also now I welcome our resource person, Dr. Priyank Jain, and request him to commence the session. Dr. Priyank Jain?
Yes.
Please commence. NCCCR, Doha.
Can I start?
Hello. Am I audible?
Yes, yes.
Please come as a session. Did you get my intro?
Yes. That's why I'm asking, can I start?
Yes, please. Please start the session.
Very good evening, everyone. Thanks to RX India for giving the opportunity to talk about lymphedema and physiotherapy management or physiotherapy importance in lymphedema management. Myself, Priyank, and I am working here as a physiotherapist and lymphedema therapist in National Center for Cancer Care and Research in Hamad Medical Corporation. And welcome to all participants who will join this session. Hope this will be useful in your career and your day-to-day practice in physiotherapy. So this is my disclosure that the presenter has no actual or potential conflict of interest in the relation to this presentation. There is some issue that I am not able to change the screen, so I will tell the sir, he will change. So sir, please change the next slide. Please change the slide. Okay, so we will start with, I think you all know about the basics of lymphatic system. So we will start with anatomy and some physiology of lymphatic system and how the lymphedema is start. So you know we have a blood circulatory system in our body and lymphatic system. So in lymphatic system, it is a not like a closed system like blood circulatory system. In blood circulatory system, blood is going from the heart towards the body and coming from the body towards the hearts. But in lymphatic system, it's not a closed system like blood circulatory system. It's coming from body towards the hearts. There is no two-way system. This is only one-way system. Like the blood circulatory system, for blood circulation, there is pumping organ known as heart. But here there is no any central pump like a heart. But it has their own something that which can initiate the lymphatic flow. We will discuss in later. It travel through many successive lymph nodes. We will discuss later on in this section. There is some not like its structure present in our all over the body in this lymphatic system, which is known as lymph nodes. This is the accessory route, the fluid or the part of the blood which is not able to come by the blood circulatory system is coming from the lymphatic system. And it drains those substances that cannot be drained or reabsorbed by the blood circulatory system due to the larger size. Next. Please change the slide. Please change the slide.
It will take few seconds. That's why.
Okay. So what are the component of lymphatic system? The main component is the fluid, which is known as lymph. We will discuss what are the part of lymphs in later slides. Lymph vessels, which include lymph capillaries, which is the initial part of the lymphatic system, which makes the lymph. Then lymph vessels. In lymph vessel, we will include like lymphatic pre-collectors or lymphatic collectors. When you see the like detailed anatomy, then lymphatic trunk and lymphatic ducts. We have a lymphatic organ also in our body, which is situated in a different part of the body. This is thymus, lymph nodes, spleen, tonsils, and also in our intestine, there is lymphatic organ is Peyer's patches and lymphatic cells. So what is the lymph? The part of the blood which is absorbed by the lymph capillaries, or we are also called them initial lymphatics, is known as lymph. What are the content? It's originate from interstitial fluid, similar to blood plasma, but rich in lymphocytes or protein. So what are the composition? Main is water. Second, and high in protein. It's include long chain fatty acid, cell fragment, and some cell debris and bacteria also. This is the component of lymph. So we will continue with the lymph, then come to the lymph vessels, which is first is lymph capillaries. So what is lymph capillaries? So lymph capillaries are the beginning of lymphatic system. They are the one who is responsible to make the lymph, made up of single layer of endothelium cells. The difference between blood capillaries and lymphatic capillaries is this: the lymph capillary doesn't have any basement membrane, but they have attached anchoring filament which is connect to the surrounding connective tissue. You can see in the diagram the arterioles, venules, lymph capillaries, they are attaching to the some filaments which is known as anchoring filament, which is also responsible for the movement in the lymph capillary, which is responsible for the movement of the lymphatic fluid. Next. Yes. So lymph vessels, they are different types. The vessel which is starting from the lymph capillaries, pre-collector, then they are connecting to the collector, then similar to the blood vessels. So if we describe about the lymph collector, it's almost similar to the veins, but there is some changes between lymph collectors and veins. Like in the lymph collector or lymph vessel, the valves are closer. In the blood in the veins, the walls are little bit far. So similar to the blood vessel, they have three layers like tunica interna, tunica media, tunica externa. Valves are present, well developed muscle layer. They have afferent and efferent. Next. Okay, so now we will come to the lymphangion, which is the main functional unit of lymphatic system. So when we see the lymph collectors, there is intermittent valve. The structure which is present between two valves is known as lymphangions. It is the structure which is responsible for the lymphatic flow or lymph fluid movement. So you can see the proximal valve, distal valve, the structure between the two valves is known as lymphangions, and the activity which helps to move the lymph is known as lymphangiomotoricity or lymphangio activity. We can say both lymphangio activity or lymphangion motoricity. And the muscle layer which is present in the lymph vessels or lymph collector is supplied by the autonomic nervous system sympathetic part. So the lymph fluid is depend first to, or the lymphangiomotoricity depend on two things. First, what is the intrinsic factor? It is intrinsic factor, the factor which help to initiate the movement is the autonomic nervous system. Second is the extrinsic factor, which include breathing, which include the muscular movement nearby the lymph collector, the negative pressure of central venous nervous system. These are the part or massage. These are or we can say later on the manual lymphatic drainage. These all are the extrinsic factor by which we can increase the lymphangiomotoricity. Next. So now come to the largest part of the lymph vessels is known as lymphatic duct or lymphatic trunk. In our body, we have two main lymphatic duct. One is right side or one is the left side. The main lymphatic duct is known as thoracic duct, which is present in the left side. You are seeing in the diagram their drainage area. In our body, the right side means right upper limb, right half quadrant of the chest and back and right side of the head and neck is drained by the right lymphatic duct. And the left side of the head and neck, left side of left upper arm, bilateral lower limb, abdomen, and left side of the chest and back is drained by the left thoracic duct, or we can say only thoracic duct. So the right lymphatic duct is draining approx 1/4 of the total lymph in a day, and 3/4 is drained by the main thoracic duct. And you are also able to see they are connecting at the junction on the both side jugular, internal jugular vein and subclavian artery. Right lymphatic duct will go to the right side junction and left will go to the left side junction. Next. So we completed the lymph vessels. Now the lymph nodes. In our body, there are many lymph nodes which is connected to the lymphatic system, and they are a small vein-shaped side structure present throughout the body. Their main function, they are helping to concentrate the lymph, and they are providing the immunity by the help of macrophages or lymphocytes. In the structure, you will find the two part, but outer part is known as cortex and inner part is known as medulla. And all over the body, we have approximately 600 to 700 lymph nodes. The most lymph nodes is present in the intestine area, but also present in the head and neck area. Next. So lymph organ. I already told when I explaining about the parts of the lymphatic system, there are different organs situated in the different part of our body. Tonsil is a lymphatic organ situated in the oral cavity, means on the pharynx, which is also known as policeman of upper cavity. Then the thymus situated in the chest. Paired spaces situated in the intestine. They are also guarding the intestine for the infection and all, and they are also responsible to for the protection of or immunity of the intestine. Then these all are the lymph nodes and spleen. So these are the lymphatic organ. So this is complete the brief anatomy about the lymphatic system. Next. So now we'll discuss about when we discuss about manual lymphatic drainage, or when we treat the patient who has lymphedema, we know about the watershed or anastomosis or tributaries. So in our body, there is some watershed which is separating the tributaries. So tributaries, or we can say the regional area or root area, we have a set of lymph nodes in our body. I will explain, like in axilla, we have axillary lymph node. In the inguinal area, we have inguinal lymph nodes. So watershed are the invisible line which is dividing the two parts. So in this, if you are seeing on the top near to the neck, this is known as clavicular watershed. Just between the body in the sagittal line, we have a sagittal watershed. At the umbilicus, we have a transverse or horizontal watershed. At the down, we have back of the clavicle, we have the spine of scapula watershed, and the down horizontal, we have the gluteal watershed. So these watershed is dividing the tributary area. Like if I will say sagittal watershed, the area between right clavicular, median sagittal front and horizontal go to the back, median sagittal and full horizontal, or spinal or scapula right. Just imagine these full watershed is the tributary area of right axillary lymph nodes. So we are dividing the full trunk in the four parts: right upper quadrant, left upper quadrant, below the horizontal, right lower quadrant, and left lower quadrant. So right upper quadrant is tributary area of right axillary lymph node. Left upper quadrant is the tributary area of left axillary lymph node. Right lower quadrant is the tributary area of right inguinal, and left for the left. So this is the watershed. By the help of this watershed and anastomosis and the quadrant, we are draining the lymph when anyone have lymphedema. Next. So function of lymphatic system, as we all know, this lymphatic system is mainly responsible for the immunity, but is also responsible for the fluid balance. So maintaining the balance of fluid in the blood versus the tissue. So just wait, yes. So fluid homeostasis. How the substance which is filtered by the blood capillaries and not able to come by the veins, it is coming from the lymphatics. So it is maintaining the fluid balance. Second, forming part of the body immune system and helping defend against foreign bodies such as bacteria by the help of macrophages or lymphocytes. Facilitating absorption of fat and fat soluble nutrients in the digestive tract. The lymphatics, which is present in the digestive tract, is known as lacteals, and they are responsible for the absorption of fat and the fat soluble vitamin, which is known as vitamin A, D, E, or K. Next. Now, so we will discuss about the lymphedema and edema. What are the difference between both? So edema is a symptoms which can occur due to heart problem, can occur due to protein problem, can occur due to the renal problem. But lymphedema is a disease which already proven by the WHO that this is a disease, is a chronic condition. Next, come to the in lymphedema. This is wrong, I think, little bit. The slide little wrong. Lymphedema, fluid accumulation, but it is a high protein. This slide should be changed. This is the typing mistake. And fluid accumulation in the extracellular space. This is low protein. This is edema. This only second point should be changed. Lymphedema occurs due to the injury in the lymphatic system. It occurs due to the injury in the or due to some problem in the circulatory system. Lymphedema did not respond to the diuretics. I will explain later. And edema respond to the diuretics, means any things which is helping to decrease the fluid. Lymphedema is a chronic condition, progressive condition, slow onset, and increase the risk of infection because it is high in protein, and protein is the culture medium of the bacteria. If it is not treated, there is chance of again and again infection. Edema complete resolution is expected after treatment of underlying cause or underlying disease. Next. So, what is lymphedema? So, lymphedema, I already told, it is a disease, it's a progressive chronic condition, it is an accumulation of the extracellular fluid, but it should be protein rich in the tissue space. And it occurs due to the imbalance between the interstitial fluid production and its transport. Yes. If lymphedema happen, it will cause further more inflammation, further more fibrosis. So this is the definition of lymphedema. Next. Sign and symptoms of lymphedema. It's not full slides, sir. Coming. We can wait. Yes. So lymphedema, it's a slow onset and it's progressive. Slowly it will increase. There is one point I written as here is progressive. Means if lymphedema is there, it should be progressive. Means it will be chronic. onset is slow, not sudden. If you will feel or if you find the sudden onset of lymphedema, there is always question mark in the cancer patient, means there is some chance of recurrence of cancer. So on the recurrence of cancer, it will be rapid, but normally it is a slow onset and progressive. Next, pitting will present, but in early stages. In later slide, we will discuss about the stages of lymphedema. So we will discuss about the pitting and non-pitting. So pitting will present, but should be in early stages. It always start distally. Squaring of toes, stemmer sign, dorsum of foot, buffalo hump. You will feel these signs, or loss of ankle contours, or asymmetrical if bilateral. Normally, lymphedema is asymmetrical if present bilaterally. Sometimes symmetrical, but not always. Mostly it's asymmetrical. Now I will explain about the stemmer sign. So it is the main means presentation in the lymphatic lymphedema patient. If you will able to pinch the skin at the proximal phalanx on the hand or in the second toe proximal phalanx on the foot, if you are able to pinch this skin, hold, then the stemmer sign is negative. But in the lymphedema, you are unable to pinch or hold the skin. Means if it is you are unable to pinch or hold the skin, means the stemmer sign is positive. So this is the stemmer sign. Dorsum of the foot, buffalo hump. I already told is start distally, come to the proximally. If it is a start proximally, again there is again question mark. It should be thinking maybe there is recurrence. You can find proximal lymphedema, there is recurrence of the cancer. I already told it is a protein rich fluid, and protein is a culture medium of the bacteria to grow. So there is chance, if it is not treated, there is chance of again and again infection. Rarely painful. When it is increasing, person or client may suffer like heaviness, achiness, or discomfort. Skin changes in the later stage. Coming slide, we will explain the stages. So when we will go above the second stage, there is some changes in the skin. There is some problem in the skin, or tightness in the skin, or rigidity in the skin. So these are the common in the lymphedema. Next. Next, sir. Okay, who is at the risk of lymphedema? Yes, obese cancer patient. Previously, still nowadays, the lymphedema is more common, the area which is more for filariasis. But nowadays, it is more in cancer patients. So those with cancer that has spread to the lymphatic system. People who have undergone the treatment for breast, prostate, uterine, or lymphoma, melanoma cancer, either surgery, surgical removal of lymph nodes, chemotherapy, or radiations. Those who have been injured or sustained trauma to the body that damage the lymphatic vessels or nodes. We will discuss in later slide how the trauma will affect the lymphatic system. And also again chance of infection. So these are the person who are at the higher risk. Also the area which is common with the filariasis is common. Next. Yes, so the types of lymphedema. There are two types of lymphedema, primary and secondary. So mainly primary lymphedema is a congenital. Means it will due to either the absence of lymphatic system, or there is less number of lymph vessels, or sometimes there is more number, means hyperplasia, aplasia, or hypoplasia. More number in the lymphatic vessels, but they are not functioning. So these are the main cause of primary lymphedema. So it is rare, inherited condition maybe. So we will say hereditary lymphedema. Developmental defect of lymph vessels, I already explained, either absent aplasia, less in the number lymph hypoplasia, or hypoplasia, but it is not functioning. So broadly, we divide primary lymphedema in sporadic and hereditary. In sporadic can come at any time, and the primary out of primary lymphedema, sporadic is more common. Congenital lymphedema at the birth. Next, from the age first till the 35-year, if lymphedema is there, it is known as lymphedema precox or early lymphedema. After 35, it is lymphedema tarda, mostly in sporadic, 80% in lymphedema tarda. Once we'll come to the hereditary, is starting from the birth. It's known as type 1 or type 2. In type 1, we are saying Milroy disease, and secondary is the Meager disease. So these are the primary lymphedema. Main cause is the developmental defect in the lymphatic system. Next. Secondary lymphedema due to lymphatic filariasis, cancer or treatment, injury or trauma. If there is tumor which is restricting the movement or blocking the movement of the lymph or lymph vessels, recurrent infection, chronic venous insufficiency, dependency edema in bedridden cases, chronic, and burn. So these are the secondary. One thing I also want to tell you, sometimes the primary lymphedema is common with some syndromes. You can find lymphedema in these type of syndrome like yellow nail syndromes, Klinefelter syndrome, Turner syndrome. You will find in some patient there is lymphedema. This is also part of, we are saying the primary syndromic lymphedema. Next. Yes, so we come to the stages. So what are the stages of lymphedema? It's like 4 stages: latency stage, stage 1, stage 2, stage 3. We will divide the stage not depending the swelling girth. There is changes in the skin. We will divide the stages. So next slide. Okay, so latency stage is a preclinical stage. There is one term transport capacity. If someone want that, I will explain. Otherwise, this is the pathophysiology or physiology of lymphatic system. So when there is no visible swelling, just a complaint of heaviness or achiness, or the person is feeling, okay, my cloth or my ring or my jewelry is becoming tight, or heaviness, but there is no visible swelling. It is latency stage or preclinical stage. If there is no treatment, then it will change to the stage 1. There is reversible lymphedema, means a person wake up in the morning till the evening, there is increase in the swelling, but it will respond to the elevation or rest. Means the swelling will be again at the lower level in the next morning. There is pitting present in this stage, and there is no fibrosis, means hardening of the skin. When again there is no treatment at stage 1, it will become to the stage 2. It will not respond to the elevation. Pitting might be present or not, and the later stage of second 2, you will find the fibrosis. If again there is no treatment in the late second stage, it will lead to stage 3, means there is hardening of the skin, there is more fatty adipose tissue or thickening of the skin. It will not respond to the elevation, and there is high protein in the interstitial place. So this is stage 3. We are also saying lymphostatic elephantiasis. Next. So these are the location where you can find the lymphedema. It's yes, extremity, upper limb or lower limb, genitals, intestine due to the intestinal surgery or any tumor surgery in the abdomen, and head and neck. Next. Diagnosis. So diagnosis depend on medical aspect, special diagnostic imaging, and your lymphedema assessment. So medical aspect is depend on the primary physician. They will do the differential diagnosis. It is related with the heart disease or renal disease. They will find the liver function test, renal function test, cardiac markers, everything they will, or blood parameters to diagnose the protein level and all. So this is medical. Once we'll go the spatial imaging, they are using ultrasound for seeing the rule out the DVT, deep vein thrombosis, color Doppler ultrasound to see the proper venous flow. There is special test which is more popular as a lymphoscintigraphy. In this, they are using the nuclear test. It is a nuclear test, and they are using one radioisotope and they are injecting at the web space either in the toes or between grade 2 and the first toe, or they are using they can insert here, and they are scanning the fluid movement by the gamma camera. You can see how the fluid is going. If there is some problem in the lymphatic, fluid will not move. So this is the lymphoscintigraphy. Yes, CT scan, MRI. They are helping in the seeing the appearance of the lymphatics. In lymphatics, normally beaded appearance, or sometimes they are seeing the honeycomb appearance, the thickness of the skin. Bioimpedance is a really very helpful in the early detection. And pyrometer, there is one optic electronic device which is helping to measure the girth, and endocyanine greens. These all are the techniques by which we are diagnosing the lymphedema. And your lymphedema assessment. So in lymphedema assessment, you have to go with a thorough history. So normal history of the patient, cancer history, any trauma history. This is the second side, but I will explain little bit normal history. I told you any trauma history. I told about the primary lymphedema. In primary lymphedema, I explained about the lymphedema precox and lymphedema tarda. Person will be okay maybe at 20, 23rd year, 23, 25-year-old. He have some problem, he or she has some problem in the lymphatic system, but there is no lymphedema till now. But any small trauma, even ankle twisting or ankle sprain, can lead to the lymphedema in that person. So that's why thorough history of the trauma. If there is any cancer history, normal medical history, cardiovascular history, you have to take the thorough history of your client or your patient. So cancer history, any infection history, any trauma history, any family history, so you can correlate with the genetics, and any travel history. This is also found that if lymphatic system is already damaged or they will travel, so in the airplane there is some chances of disturbance in the pressure. It will also initiate the lymphedema. So this is the summary, how we have to take the thorough history, everything related to the client or patient. Now lymphedema assessment. So in lymphedema assessment, we will assess the swelling. There is different things how we will assess the swelling, how we will measure the swelling. Assessment of tissue changes, I already explained the pitting or non-pitting or fibrosis. Or in the later stage, you will find some changes in the skin of the lymphatic lymphedema patient. Severity, it's depend on the how much difference between affected and the unaffected limb. And pain. Next. So this is the normal, this is the circumference limb measurement. Till now, it is the main tool for assessing the lymphedema. We are assessing first, means in the hand, normally we are taking like every 4 centimeter gap or the 6 centimeter. And in the hand, we are taking every 6 centimeter or 8 centimeter, depending on the limb size. We are starting with the first, we are doing the metacarpal. Then we are fixing one point at the styloid process, or in the lower limb, we are fixing the point at the lateral malleolus. Previously in the foot, we are taking the first measurement, the metatarsal. Then after there is 6 centimeter, then the ankle, then starting every 6 centimeter till the thigh, and here will reach till the shoulder. So these are the first that circumference measurement, and there are some software when you put the marking in the centimeter, they will change in the volume. Next. So this is water displacement meter. This is also useful for checking how much difference in the volume in the affected and non-affected side. Next. So assessment of the skin, I already explained about the stemmer sign. Here is some picture. If you are able to pinch the skin at the proximal phalanx or at the toe, base of the toe, it is negative. If you are unable to pinch the skin, stemmer sign is positive, which is common in lymphedema. Dryness of the skin, pigmentation, fragility, redness, dermatitis. Common infection is known as cellulitis, fungal infection, and hyperkeratosis. Is depend on different types of lymphedema, how it is managing, or there is treatment or not. So you will see sometime lymphuria, there is oozing of lymph, there is tightening of the skin, hyperkeratosis, there is some nodules coming to the skin, papillomatosis. So these are the different skin changes you will see in the lymphedema patient. Next. Severity. You will find that affected and unaffected extremity have less than 20% limb volume. Then difference, this is mild. Between 20 to 40 is moderate, and above 40 or 50 it is severe. So depending on the severity or depending on the stage, the lymphedema therapist is deciding the treatment. Next. Yes, so always we are physiotherapists, movement specialists. Always in medical field, prevention is better than cure. So proper exercise. If you have any post-cancerous patient who underwent any surgery, they removed the lymph nodes, or he or she underwent radiation, or the person is staying nearby you, or he came from any that pandemic, that area which is filariasis is common. So these are the some prevention regular exercises. I already told you that the functional unit is Lymphangion, the extrinsic factor which help to increase the Lymphangion activity is the muscle pumps. So exercise will help to increase the Lymphangion motoricity. Air travel, there is chance of increased lymphedema. So proper stocking before air travel. Proper skin care. If there is no proper skin care, there are cuts in the skin, there is chance of infection and lymphedema. Once there is chance, again and again infection, there is again and again damage to the lymphatic system. Avoid BP injection and blood test on the affected side, because again, if there is blood test, there is chance of thrombophlebitis. So again, there is chance of infection. Avoid repetitive and vigorous movement on the affected limb. We can do repetitive and vigorous movement, but if we are following a good lymphedema therapist or good exercise regime, because nowadays many research is published, yes, resistance training is helpful in the lymphedema, but it should be customized, it should be tailored. Avoid hot bath. Once you will go the physiology of the lymphedema, there is active hyperemia, passive hyperemia, high volume failure, low volume failure. So you will see if there is hot bath, there is chance of active hyperemia. So there is chance of more tissue filtration, there is chance of more lymphedema in these type of patients. So these are the prevention. Next. So what are the treatment? Medical. In medical, some natural medicine, I think benzopyrones. This is little bit question mark. Diuretics is not helping in lymphedema. I already told you, if you will give the diuretics, lymphedema is already protein rich, less water as compared to edema. So if you will give the diuretic, this patient, the water loss will be increased. So there is more chance of thickening or more chance of adipose tissue. So still, but some places still diuretics is prescribing in lymphedema. So this is the medical treatment. I will not able to discuss more. This is that part. Surgical, yes, there are some type of surgery, debulking surgery or Charles procedure, lymphovenous anastomosis, lymph node transfer surgery or liposuction. So this is a surgical part, but there's still many research or many new technique is going on surgical intervention. And now the main topic for today, how we will manage lymphedema conservatively, where our role is important, which is known as complete decongestive therapy or complete decongestive physiotherapy. So till now, this is the gold standard treatment for the lymphedema patient for management. Still, there is no cure of lymphedema, but there is management of lymphedema. We will reach almost near normal stage if we follow this treatment. So it has 4 parts. There is also one more part, patient compliance or their self-care, because self-care is the main part in lymphedema management. So first is skin care. We have to care skin, so there is less chance of infection. If there is no infection, so there is more chance of lymphedema management. There is a special type of draining technique is known as manual lymphatic drainage. There are different schools which is explaining the different type of manual lymphatic drainage. Compression therapy is also depend on the phases of the lymphedema management and the exercise. Next. Yes, so conservative management or complete decongestive therapy has 2 parts. Intensive phase means first is the decongestive phase, then second is the maintenance phase. Next. So intensive phase, both have common things. In both, there is manual lymphatic drainage, but in the maintenance phase, we have to teach the patient for the self manual lymphatic drainage. Compression, here self-bandaging or pressure garments. Skin care is common in both, and exercise. Next. So intensive phase is depend, patient is seen on a daily basis. It depend on the severity of the lymphedema, which stage you are saying first or second or third. So it depend on patient to patient, like 2 weeks, 3 weeks, you have to see regularly. Treatment given until the affected part decongested. We have to take the measurement on every week or every 2 weeks. Once it will reach the plateau, means now there is no decrease in the further circumference measurement, then it will change to the maintenance phase. Patient is thoroughly informed about the CDT, especially self-management. Duration depends on severity of the condition. I already told it's depend on the stages. So either 1 week, 2 week, 3 week, or maybe 4 week. Treatment and determined by the result of reassessment. Means once you will check again circumference measurement, there is now no reduction in the size, then we will change to the next stage, means maintenance phase. Next. So improvement of self-management phase, when measurement approach a plateau stage, means there is no further reduction in the limb size. Patient assume responsibility for managing result of phase 1, either patient or their caretaker. Proper daily skincare, compression garment have to worn daily. In the second maintenance phase, either they can use compression garment or even bandaging. Compression bandaging at the night or 24 hours. Self MLD and exercise daily, and lifelong process, regular checkup of infection and other parameters. Next. So we have to, these are the some recurrent infection. You will see the 2 different skin. One is a normal intact skin. Second is there is infected skin. So wash daily using proper pH soap or proper pH cream. Low pH cream we have to use. Clean and dry skin fold. There is, if you go in the second or third stage, you'll find there is many bulky area. So we have to clean each and every fold. Monitor affected and unaffected skin for the cuts. So apply proper lotion and avoid skin scented product. So we have to follow the skin care even in the intensive phase or the maintenance phase. If there is no skin care, there is chance of infection. Next. Yes, so MLD. So it is not a massage you are seeing in the picture. If you will do massage, there are chance of further damage or remaining lymphatics. So it is a gentle manual technique. We will put the pressure, you will have like baby below than 1 year. If you put your palm on his head, there is anterior fontanelle and posterior fontanelle. However, putting the hand very softly. That pressure we have to do the MLD, not too much deep. Encourage fluid away from the congested area by the increasing activity of normal lymphatics and bypassing ineffective or obliterate lymph vessels. In the initial slides, that's why I put anatomy. I explained watershed and anastomosis. So we have to make a diagram which lymph nodes is removed. Then we have to drain the proper rerouting of the lymphatic lymph fluid. And in this part, yes, okay. It's always proximal to zista, means if we treat the right hand, then we will first clean the unaffected area. So we will reroute the fluid. So this is suppose this is right hand affected. So first we will clean on this side. Then we will clean from there to there. Then we will start from proximal to distal. Next. So what are the effect goal? So CDT goal, treat lymphedema properly, manage lymphedema, reroute lymph flow, increase lymphangion motoricity. I already told you, extrinsic factor is massage also, because it will soothe the lymphangion motoricity, it increase the lymphangion motoricity, and suction effect, and what is this? Yes, reduce the lymph girth. So these are the goal of MLD. Next. Effect of MLD, it increase the lymphangion motoricity, as I already explained, in the extrinsic factor which is affecting the lymphangion motoricity, reverse of lymph flow, increase in venous return, soothing effect, and analgesia. Next. So these are the some diagram by which therapist is deciding the route to drainage by the help of MLD. There are different regional lymph nodes. There are again lymph nodes. So depending on the diagram or depending on the condition, we have to make the proper lymph rerouting channels. Next. So compression therapy is based on the stages of the treatment. So either multi-layer lymphatic bandage, we are saying MLLB, compression garment, or intermittent pneumatic compression, IPC. Next. So we covered skin care, we covered MLD, now the compression. So effect of compression, it reduces the further filtration of interstitial fluid. It increases the reabsorption, prevent reaccumulation of the fluid, and improve efficiency of the muscle, but we have to continue with the exercise during compression. Next. Yes, so these are the part of different material we are using in the multi-layer bandaging technique. These are the things: restore shape to the lymph or affected area, reduce skin changes such as hyperkeratosis and papillomatosis, support overstretched inelastic skin, eliminates lymphoria, means the oozing of lymph nodes, and soften subcutaneous tissue. These are the effect of multi-layer lymphatic bandage. Next. So normally in the market, we are seeing two types of bandage. Short stretch, we are normally seeing the normal stretch, which we are normally using in the orthopedic. So this bandage is known as long stretch, and the bandage which normally lymphatic in the treatment of lymphedema is using is a short stretch bandage. So these are the main difference in long stretch and short stretch bandage. High bunkering pressure is in the short stretch bandage. That's why once we apply the bandaging, we are saying to the client that they have to go with the normal movement in exercise. So if they will do the exercise, there is high working pressure and there is more reabsorption of the lymph fluid. There is low resting pressure, but in the long stretch, there is high resting pressure. It stretches from 30 to 60%, but in the long stretch, it will stretch from 150 to 300%. So in the lymphedema treatment, normally we are using short stretch bandage. Sometimes we are using long stretch bandage, but it should be in palliative care. So these are the different diagram. Resting pressure, working pressure. In one, there is muscle is acting. Second is muscle is not active, and you are seeing the pressure difference between resting phase and the working phase. Next. So part of MLB means multi-layer lymphatic bandage, finger or toe bandage. There is tubular bandage or tubular gauze. Then soft synthetic wool is depend on the stage of lymphedema. Sometimes we are using normal Salona, means the bandage or the cotton-like structure. Sometimes we are using little bit hard, which is also known as foam-like structure, which is a big one in this picture. Sometimes using more hard when there is more fibrotic changes. We are known as complex. So finger or toe bandage, tubular bandage, soft synthetic wool, dense foam, elastic or elastic bandage, or for the proper management, there is measurement tape, and for the holding the bandage, we are using the tape or micropore or paper tape. Next. So these are the different part. There is tubular bandage, there is finger bandage, there is normal bandage and foam roll. If you will find the more fibrotic, then use dense foam. Next. So multi-layer bandaging principle is depend on this equation. P is the pressure. I think 2 slides before there is working pressure and resting pressure. P is the sub-bandage pressure. Means, no, it's okay. This is the diagram where you will find the pressure. So P is the sub-bandage pressure, the pressure which is just beneath the bandage. T is the tension. So normally we are not pulling the bandage and we are not losing the bandage. We just overlap in a normal tension. So always tension should be constant. And 4630 is constant number. So we are playing with N means number of the layers, C limb circumference, and W width of the bandage. If you follow this, then you will find a proper pressure gradient from the distal to the proximal. Next, I will explain in this next diagram. Just remember this. See, so we are making a conical shape. If we are using the hand, so we are making here less circumference, here more circumference. So if circumference is less, sub-bandage pressure is high. So normally here we are using like 3 layer, same in the lower limb we are using 3 layer. The number of the layer is directly proportional to the sub-bandage pressure. So circumference is low, pressure is high. Number of layer of bandage is high, pressure is high. And the width of bandage is also inversely proportional. Width is less, pressure is high. So in the lymphedema multi-layer lymphatic bandage, we are using here 6 or 4 centimeter followed by 8 followed by 10 or 12 depending on the limb size. In the lower limb 6 or 8 followed by 10 or 10 or 12. So if the width of the bandage is increasing, pressure is decreasing. So this is normal explanation. So it's also depend on your patient to patient. Maybe sometime you will use 6 centimeter in lower limb, or some patient you will use that foot size is higher, longer than you can use 8 centimeter. But after 8 centimeter, there is 10, then 10, then 12. In the upper limb, 4, 6, then followed by 8 or 10. And proper conical shape from the distal to the proximal and the number of layers. So this is just for understanding. Next. So compression garments, it's also depend on, there are many, in further slide you will find the different parameters or different companies or different means different state. There is some differentiation in the pressure, like class 1, class 2, class 3 compression garment. Some companies produce in class 4 also. So these are the some quality which we have to see in the compression garment. Now there are more compression garment. Now there is custom made or ready to wear. So there is also some differentiation. There are also differentiation in flat net or circular net. So when you will do the more practice in lymphedema management, you will find these all garments. Now previously there is no garments in the night. Now they already launch night compression garment also, if patient is unable to wear the bandage in the night, so they can use the night compression garment. So please next. So these are the some classification: class 1, class 2, class 3, class 4. Normally in upper limb, we are using class 2 compression garment. In the lower limb, we are using class 3 compression garment, or also it depends on the patient tolerance. Sometimes patient cannot feel to tolerate that pressure, so we have to reduce this class. So in upper limb, we can use class 1, or sometime patient can tolerate, then we can go for class 3 in upper limb, or it's depend on your assessment with the patient or patient tolerance. Next. Yes. So intermittent pneumatic compression is also a device, electronic device, which we can use like 30 to 60. Sometimes some research are saying that we can use 100 mm Hg of pressure. It's normally 30 to 120 minutes. So this is some research are saying that it is mimic the MLD, manual lymphatic drainage. Previously there is 4 chambered, 12 chambered, 6 chambered. Now in the market there is more advanced machines in 10 chambered or 12 chambered. Now there is also machine for the unaffected area. So they are draining, first clearing the unaffected part, then the affected, then they are also doing from proximal to distal. So these all are the muscle which also help in the compression. It is mostly useful in lymphedema. Nowadays there is still underdiagnosed condition in mostly in, it is occurring in the female. There's a lymphedema. There is bilateral symmetry, means there is symmetry, but in the lymphedema there is mostly there is asymmetric. In lymphedema the foot is involved, but in the lymphedema there is no foot involved. It will also lead to lymphedema. So the lymphedema also it is useful. Next. I think we reached almost end. Yes, contraindication. So there are different contraindication. I just note down a absolute contraindication relative. Absolute, if you find there is any acute infection, there is any cellulitis, stop your CDT. First, start with medical management, either oral antibiotic or IV antibiotics, depend on the physician. Once the symptoms is solved, then assess the client and go with your further assessment or further treatment. Untreated congestive heart failure, no need to do anything. Acute DVT, sometime in acute DVT, if the client or patient is on ongoing anticoagulants, then we can go with, but again we have to discuss with the treating doctor and pay client symptoms, then we can go with the pressure garment. Not that much, like we can go with class 1. And some relative, yes, there is palliative care. It is care which we are giving to improve the quality of life and the end of the life. So sometimes you are you will see there is recurrence in breast cancer, or it is involving the lymphatic system, and there is edema. So little bit cautious and assessment again and again with the patient. Then you can decide your MLD or compression garment you want. You will able to give the garments, or you can go with the bandaging or decrease the size of bandage or whatever. It depends on your assessment. Yes, it help in pain relief in a palliative setting, or also if client is hypertensive, or there is controlled hypertension, means he is on already on the medication. So these are the some indication, contraindication, and also there is some contraindication when we are doing the manual lymphatic drainages, because we have to clean the unaffected area, we have to clean the regional lymph nodes. So there is some contraindication for the neck MLD, some contraindication for the abdominal MLD, because if abdominal MLD is contraindicated, then most things is breathing exercise, because in the lymphatic system there is one part which is situated just below the diaphragm at the L2 level, is known as cisterna chyli. It is also saying that's the lymphatic heart. So it will help to the increasing the intra abdominal pressure. It helps in the suction effect, which ultimately help to move the lymph towards the heart. So if there is hypersensitivity in the carotid sinus, or there is cardiac arrhythmia, so or hyperthyroidism, if there is hypothyroidism, then there is chance of, we will do the MLD at the neck area, then there is chance of some thyroxine hormone disturbance. So be cautious in this area. When we will go further detail, there is some some contraindication in the abdominal manual lymphatic drainage if there is recent abdominal surgery, or liver cirrhosis, grading of the liver cirrhosis. So these are the some absolute or relatively contraindication in the CDT, which will be proper accessible when you are in front of client. So that's why in the initial I told thorough history, and every session or every week there is reassessment and with thorough history. Next. Yes, exercise. I already told you that once we are applying the short stretch bandage, exercise is important, but it should be tailored and decongestive exercise in the proper form. If you will apply that short stretch bandage and client or patient is not doing any exercise, it is useless. They have to go with the exercise. So ultimately it will increase the high working pressure, which ultimately increase the reduction in the lymph size or circumference. So exercise movement are common. Rehabilitative intervention used to reduce edema. Exercise improve muscular strength, cardiovascular function, psychological well-being function, and also elevation of the affected limb, ideally to just above the level of heart. And always exercise should be tailorized. For upper limb, there is other decongestive exercise for the upper limb. Lower limb, there is decongestive exercise of the lower limb. You can give the proper cardio training or proper tailored exercise resistant training according to your client and patients. Next. So I think we almost reach in the end. So must be performed with compression. I already told a patient as an intensive phase, multi-layer lymphatic bandage, or in the compression garment, they have to go with the proper exercise. Keep it simple and slowly and progressive, depending on the your assessment. Light to moderate intensity in cardio training, 5 to 15 repetition, 1 or 2 3 times in a day, and include all general joint range of motion exercises. Next. Thank you, I think.
Dear participants, those who are watching in YouTube, if you have any doubts, type the doubt in the comment section, or you can check your WhatsApp message. I have sent you the Zoom link. If you want, you can join with us in Zoom to ask the doubt. Those who are joined in a Zoom meeting, if you have any doubts, kindly ask our resource person now. Any doubts?
There is some message. Thank you so much, sir. Archana Raut. How often should the bandage be changed?
Thank you so much.
So, Risika, how often should be the bandage be changed? It depend. Normally, short stretch bandage last long till I think 3 to 6 months. Or if you find that patient is not maintaining a good clean and all, proper doning and offing, you have to explain with the patient, then you can change the bandage. It's your subjective assessment.
Any other questions? Yes, let me check YouTube once.
Yes.
So a few appreciations are there, and
Book for lymphatic
from
drainage.
Sakshi Varma, thank you, sir, to provide more information about
There is one.
lymphedema, and there is one.
Arsad Ali. Sir, please suggest any book for lymphatic drainage. There are many books, but lymphatic drainage, there are different schools of thoughts. One is Foldy technique, Woda technique, Kelly and Smith. So it depend on you which technique you want to follow, or Lodok method. So there are different type of lymphatic drainage book. So it's better to, I suggest go with the course rather than go with the book, because in different school of thought there are different books, but the main principle is same, that from unaffected to the affected. Cancer
Yes,
rehabilitation, there is a book, I think you can find in the Google, or there is a, you can avail, there is one book, ACSM, Cancer Exercise Specialist. You can find on the Amazon. There's Cancer Rehabilitation. And also there is one very book, I think more than 1000 pages. Cancer Rehabilitation is that title. You can find. Any course available in India? Yes, there is course in India. I think Tata Memorial is conducting 5 days course in lymphedema management. Or there is some short 2 days or 1 day's workshop in the Tata Memorial. And yes, I did my course from ACOLS. So they are conducting some courses every year or every 2 years in the India for certified lymphedema therapist. Or there are some online course you can complete, like I completed from that one academy, Pins and Steel. There is some separate women cancer specialist course or men cancer rehab specialist course. Yes.
and there is one question from YouTube viewer.
Yes.
Akshar, Kavita Akuskar. What about compression bandage? Is it better, or compression garment is better?
I already told you it's depend on the stages and your assessment. If you find that patient or client it came at the stage 1, there is no need of compression bandage. You can go with the MLD, you can go with the exercise, skincare, and compression garment. But if there is second stage, go with the compression bandage. Later on, once there is plateau phase, in your assessment there is no change in the reduction, then you can go with the compression garment. So it's depend on your assessment and the staging. There again 2 questions. Thank you so much. Okay, thank you. Sir, wanted to know about the ADLA episode in filariasis. Can you explain what is this ADLA? Sir, wanted to know about the ADLA. Can you explain what is ADLA?
Chiral, can you please explain what is ADLA? Okay, there is another one more question from YouTube viewer.
Hello.
Yes,
Hello.
yes, Chiral.
Yes, sir. So actually, we treated 2 patients in KEM hospital in Mumbai of lymphedema, filariasis lymphedema. So
Yes.
we were just going through the research and like reading evidences and articles. So we came through this factor of ADLA, which says it's acute dermatolymphangitis. Like it's like superimposed bacterial infections, and then there are skin changes and cellulitis and lot of skin conditions occurring. Like
Yes.
because of that, it's mainly due to not proper skin care. That's what they
Yes.
say.
Yes.
So I wanted to know how common is it, and like what is your view about it, sir?
So this patient completed their filariasis treatment or is still ongoing?
No, sir,
Because
the treatment.
first we have to complete the medical part. I think they are albendazole. There is treatment and ivermectin, some drug they are using from
Yes,
the
yes, 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 sir. Yeah, they were completed on that. But
not,
yeah, but they were on some yearly medications, like some inject. Yeah.
and there are recurrence of the infection in the lymphatic filariasis, and you will find the skin is fibrosed. So there is chance of
Yes, yes,
lymphodium.
sir.
There is chance
Yes,
of
sir.
hyperkeratosis of the skin. So you have to go with the proper skin care. If you find any wound, you have to clean the wound plus underlying infection. Then you have to go with the lymphatic management. If
Yes,
there is
sir.
any acute infection, stop your treatment. First, clean
Okay.
the underlying cause. Even if patient have like acute infection or he or she is already on antibiotics or underlying drug related to his disease, then you can not go with the high pressure bandage. You can decrease the pressure or you can go with the garments.
Yes, sir. Because we did refer them to the dermat and proper skin care was taken, and after that we proceeded with the treatment.
Lymphadenitis means the infection of the lymph nodes.
Oh, hello.
Yes.
Yes, sir. Yes, sir. Yeah, even the skin, the upper skin is affected. The epidermal area of the skin is also affected. Like superimposed bacterial infection comes in. That's what articles and there is.
So if you go with this patient, first apply a proper wound care, means the skin care,
Okay.
ongoing underlying treatment with the medicine, and go
Yes,
with
sir.
bandage. Go with the bandage with tolerance of the patient. Once there is decrease in the signs or decrease in the lymph, you will feel the difference. Means the skin infection is also ongoing decreasing.
Okay.
It's your assessment. If the patient is not doing proper ointment, so clean the skin. Okay, with like you
Yes,
can
sir.
use the Sablon or you can use betadine or the superficial ointment. Okay, then go with the tubular bandage, go with the Celona or Rosidil form. It's depend on your assessment. Then go with the bandage with
Okay.
less pressure. And also in this patient, you have to ask, you have to assess the cardiac history also.
Okay.
Yeah. Because sometimes if you will do the bandage in the patient because the limb size is too huge,
Okay.
there is difference maybe more than 1000 liter means one more sorry 1000 ml means
Yes,
more than 1 liter. So if you
yes, sir.
do the bandage, it will this fluid will go towards the main body circulatory system. Maybe their heart is not able to compensate.
Okay.
So
So it's
go slowly treat superficial skin with underlying medication and go with bandage and with less pressure. Slowly increase the pressure, or you can not give the bandage for 24 hours. You can give like, okay, 8 hours, then remove, then call again patient in the evening for 2 to 3 hour remove, then again go with the bandage. You can
yes, sir.
shuffle your treatment in this way.
Okay, sir. So, and there was one more doubt. Should I ask it now?
Yes,
Uh,
yes,
yeah.
please carry.
Actually, we just read that once it becomes less than 20% of the excess limb volume,
Hmm.
we can give stockings or some other like compression garments.
It is like if it
Yeah.
is less than 20%, once you will measure the
Yes, sir.
lymph size, okay,
Yes, sir.
there is one software which will change the centimeter into a volume. And if you
Okay.
will find there is one is marking is 21, other is 23. If you will find that there is difference between less than 3 centimeter and more the readings, then you can go with the prevention. Skin means proper precaution for the lymphedema plus skin care, decongestive exercise, and it's depend on patient only. You can go with upper limbs class second garment.
So what we noticed was in lower limb lymphedema, we prescribed stockings, but the patient was not comfortable with it. Like, it was Like she herself was not comfortable, even though the size was correct, but the patient was like, I'm not able, we couldn't understand exactly why she's not able to.
Discuss with the patient what is the issue. Is she is not comfortable with doning and doping, or it is
Okay,
too much
okay.
tight? And
But
then if it is lower limb lymphedema in female, there is chance of again and slipping. So you can do the belt with the connected with the abdominal belt, so it will not slip again and again.
okay, okay. Yes, sir. Yes,
Mhm.
sir. Yes. Thank you,
How
sir.
Welcome. How to differentiate clinically swelling and edema? Clinically, I explained about the edema. So for edema is a symptoms. So you need to go in the thorough history of the patient, cardiac history, renal history, liver history. If there is any problem in this, so you need to clear the underlying cause. Then edema will be resolved. Sir, I want to know again about facial edema management. I think I have some network. So facial edema, yes, there is edema in post head and neck cancer patients, but there is very less as compared to the limbs edema, because in head and neck it's all assisted by the gravity. So there is chance of very less in the head and neck cancer patients. There is different means measuring technique in the head and neck measurement, and also we have to follow that means which lymph node they removed, which type of surgery they did, and where we have to means move the lymph, means from the affected to the unaffected area. Yes, we have to go with the neck clearance, axillary clearance, deep breathing exercise, and depending on the surgery, we have to go the lymphedema management. I hope it will be useful. Sir, how it is measured?
Yes.
I didn't understand how it is measured. Whose question privately? Can you explain whose is the one, sir, how it is measured?
I don't know who sent the message to you, or it was
It's in
a
a
private
comment.
message to you.
Uh-huh.
Take it. Otherwise, there are many questions in YouTube also.
Tell me, sir, tell me. I will
And
try.
yeah, there are a lot of thanking messages. Wonderful information was shared. And Chandralekha Saktivel is asking, sir, the MRM patients who have diagnosed lymphedema, they are complaining of abdominal swelling. Is there any connection?
You have to go with the abdominal history. If there is any Crohn's disease, any diverticulosis, or any recent abdominal surgery, go with this. There is any chance of abdominal metastasis?
Okay, thank you. And the next question is from Tadi Yoshita. If compressive bandage is pinching skin, is that bandage is good?
What? Please, sir, pardon again.
If the compressive bandage is pinching the skin, is that the bandage good?
Means if compression bandage is pinching the skin, means you didn't apply the proper conical shape. You didn't, maybe you didn't use the proper under wrap material, maybe Celona or Rosidal form. So first again recheck, and then if you cover the full skin with proper padding and all, compression will never pinch the skin, because it is above than your padding material. It's just not just under the on the skin. First, you have to apply the proper skin care with the lotion. Then you apply the tubular bandage. Then after you will apply the padding. It's depend on the lymphatic severity. Then you will apply the lymphatic multi-layer bandaging technique. I think bandage will not directly touch to the skin. Maybe my explanation is helping you. Any scale is used to
I
measure
hope.
lymphedema. There is a scale I already told. Circumference measurement is the till now is the good one. So for upper limb, take measurement first at the metacarpal, then at the Stollett process, then every 4 centimeter. In lower limb, first at the metatarsal, then after 6 centimeter, then at the ankle, means lateral malleolus, then every 6 centimeter, and compare these both measurement. If you find there is difference in like below 3, means there is mild between 1 to means there is less than 1, this mild, between 1 to 3 is moderate, above the 3 is severe. So it's depend on your measurement, and there is volume, there is proper chambered container, you have to fill the water. So this is different measurement techniques. Any one of the best, one of the best session I ever attended. Thank you so much. Sir, as there are two methods of calculating lymph volume, cylindrical method, truncal cone method, which is preferably used. Normally, I am using circumferential method here. In our hospital, we are using circumferential method, and we have the software which is changing the centimeter into volume. We don't have that volumetric method till now. And it's also not hygienic because you have to clean the water each and every patient. And you have to clean, change the water, and you have to clean that pot also.
Hello. So,
Yeah.
how can we how can we apply for the software? Is there any procedure that we need to do?
Once you will complete the course, then they are giving to you. It's a copyright material. So if you have a contact, if you are working in a hospital, then from the hospital you have to ask them to give the software, or there is some Excel person can help you how to change centimeter in the volume.
Okay. Yes, sir.
Who is expert in statistics or expert in Excel? They can help.
Okay. Yes, sir.
Sir, apart from positioning, can anything beneficial for stage 3 lymphedema? Stage 3, I already told, go with full treatment CDT, skin care, MLD, complete bandaging and exercise. Positioning only not help. Positioning will help only stage 1 lymphedema. Yes. Any other questions, sir?
That question.
Hello, sir.
Can I read it?
Yes.
And sir, from same Chandralekha Saktibel, the question is, sir, she asked abdominal swelling. Now she is asking what kind of advice can be given
for this patient.
Last question was asked by Chandralekha that MRM patient who have diagnosed lymphedema, they're complaining of abdominal swelling. So what kind of advice can be given to that patient?
First, you have to go with the medical history. They did any ultrasound or any CT scan for the abdomen. There is any finding related to the disease. There is any metastasis or recurrence or any underlying any disease. If not, then this swelling may be related with the lymphedema. Otherwise, just go with your treatment if you find that there is no clinical contraindication in these patients. Because you will drain the lymphedema in upper limb, it will not go in the abdomen. It will go directly to the, if it is the right side, it will go the right junction, or if it is left side, it will go the left junction. It will not go down. Until unless you will not rerouting the lymph from the axillary anastomosis to the inguinal anastomosis. Sometimes if there is both axillary clearance, then we have to go down and then up. But if it is only one-sided, you can drain opposite side from the front, or you can use the posterior axillary anastomosis. Yes, sir wanted to ask about
the next question is
instead of pneumatic compression and lymphedema pain point. I think no. Faradic current.
So the next question is from Sakshi Verma. Sir, can give any electrotherapy modalities in lymphedema?
Archana, yes. Seral, I am not sure. You can check. I am not that much.
Sir, can I?
Yes.
Can I just share? So what? See, pneumatic compression, we couldn't we didn't have it, or it's not easily available. So what we did was we gave an elevation searched Faradic, contractions, like 10 to 15 contractions, and it was on that we applied bandages, not the.
So rather than you are doing this search Faradic, just go with your full CDT. No need to use intermittent pneumatic compression. Just go with the skin care, MLD, and bandaging and exercise. Till now in my career, I think more than 7 years, I didn't use any sporadic. Hello, is I am audible?
Yes, sir.
So go with the CDT. In CDT, there is no surge sporadic. Yes, there are many more. Some research is going on. They are saying therapy is helping. The kinesiotape is also helping. Low level laser is helping. But this is not a part of CDT. Here I am focusing only CDT.
Okay. Okay, sir.
Sir, I am getting many patients with elephantiasis and lymphoria. So what can be done in case of lymphoria? Use proper means topical skin agent to decrease the lymphoria outer, and use your bandaging. You have to change maybe again and again bandaging, maybe within 10 days. Ask the patient to wash the bandage, explain the proper washing technique, and it will be helpful for this patient. Once you reduce the lymph or reduce the size, lymphoria will immediately resolve, immediately, maybe you're within a 1 week, because lymphoria is because due to lymphedema. And lymphedema, use bandaging upon your assessment and go with this. And also focus on medical management also in this patient. And sometimes you have to discuss with the physician that underlying antibiotic they have to be continued. Next, sir, any other question?
There are so many questions. Would you like to answer?
You are not properly audible.
There are many questions in you.
Sir, you are not properly audible.
There are many questions in YouTube.
Okay, but I am not able to find YouTube. So,
I will read it here.
yes, please.
Please don't take any questions from Zoom now. I'm going to read it from YouTube.
Okay, okay.
Yeah. So the question is from Swati Selvaraj. How long patients survive with lymphedema?
How long?
Patient survive with lymphedema.
Whole life.
Yeah. Survival of the lymphedema.
If it is not affecting the underlying system, if there is no clinical comorbidity, then go with the full life. Because there is no proper treatment till now. There is only management, which is CDT. So if there is underlying cause, heart problem, kidney problem, then there is less survival rate.
Okay, so the next question is from Rupa V. If patient have cellulitis, how many days need patient rest or restart exercise?
Discuss with your physician. If you find there is fever, chills, change in the skin, tightness, then he or she has to go with the, depend on the infection, IV antibiotics or oral antibiotics, at least give 1 week. Then start with distal, means away from the skin MLD. Don't touch on that skin. Then go with the low pressure bandage or only part of the bandage. It's depend on your assessment. And also take the clearance from your physician.
So the next question is from Chandralekha Saktivel. When can we start resistant exercise for post-MRM patients?
Post-MRM patient, assess your patient properly. Immediately, we are restricting the overhead movement for, I think, initially surgery, depend on the surgeon confidence or depending on your hospital protocol. So post-MRM patient, then slowly, once there is stitches is removed or there is invisible stitches, then depending on the patient pain tolerance, start with the exercises. Once you will find, okay, now patient is able to do the normal range of exercises without weight, like 10 repetition, 2 sets in twice or thrice in a day. Then assess the patient's strength. Then go with the light weight with high repetition, like alternate in a week, like 3 to 4 times in a week, slowly, and you have to assess the 1 RM also in the patient. And
So the next
also
question is,
immediate MRM. I think if it is immediate MRM, you have to discuss with your doctor when patient will start the chemotherapy, when patient is on radiotherapy. So if there is a radiotherapy, there is further restriction in the range of motion. So you have to focus on the shoulder mobility, scapular mobility, normal range of motion of the upper limb, and also if there is patient on chemo, there is again chance of further fatigue, which is known as cancer related or chemo related fatigue. So assess thoroughly, and it is your decision or your assessment. So that's why in mostly your assessment is your treatment. If you've done your budget assessment, your treatment is on your fingertips. Next.
the next question is from Kavita Pushkar. Sir, can you suggest good compression markers?
Compression markers, I didn't get. Can you ask?
Maybe, Kavita, if you are watching, kindly detail your question. We will go back to next question from same Chandralekha Saktivel. How long the compression garments when should be advisable? Immediate post-op or once diagnosed lymphedema?
Once diagnosed lymphedema.
Thank you. The next question is from.
I already told you that you have to, normally what we are following here, we are taking the patient pre-op, means we are starting a pre-rehabilitation here. So we are explaining the lymphedema and what will be happen in the future. So patient is aware now. So you have to catch this patient from the pre-operative phase. Once you catch this patient, patient is able to know what is the difference that I will feel. So that's why I told 0 stage is immediately post-operative. Maybe there is heaviness, maybe there is invisible edema. So, and if you advise these all risk reduction practice of the patient, if he or she is feeling there is change, he has to come to you, and it's depending on our assessment. Stage 1, then go with the compressor garment, MLD, and exercises. Next.
Okay, so the next question is from Gaurav Maji. How to differentiate with varicose veins?
Varicose vein, color Doppler, venous Doppler. If varicose vein will last long chronic venous insufficiency, it will lead to lymphedema. For that, you have to go with the pathophysiology or physiology of the lymphedema. There is mechanical insufficiency, there is dynamic insufficiency, there is high volume failure, there is again lymph time volume and transport capacity, there is different type of pressures. So once it will lead to damage to the lymphatic system, means there is mechanical insufficiency, it will lead to lymphedema. Otherwise, just go with the venous chronic venous insufficient treatment.
Thank you, sir. The next question is from Chandralekha. Sir, can you say outcome measurements for lymphedema references?
Outcome measure, you can follow National Lymphedema and Network framework. You can search on maybe some APTA website. You can search on, there is some breast cancer related, I am not sure, but yes, you can find in NNL or International Lymphology Society if you will able to find.
Okay, sir. The next question is from Tadi Yoshita. Skin is getting pinched at elbow joint. Only that she is saying.
Skin is
getting pinched at the elbow joint.
Which case? I am not understanding. This is a post-cancer patients or edema patient or lymphedema patient.
I request Tadi Yoshita to write the question clearly.
How I can understand pinch at the elbow joint?
So the next question is from Chandralekha. Sir, joint range of movement exercise for MRM patients immediate post-op. Is there any duration of time or reputations?
If you go in a different website of the breast cancer rehabilitation, there is one breast cancer rehabilitation course. I think class training is going on, or there is some recommendation from the different society. So it's depend on your assessment and your surgeon's protocol. Once there is no pain, there is initial restriction, then go with the active range of motion exercises in pain-free range. Always consider the pain.
Okay, sir. The next
How is the progression of congenital lymphedema? Cyril.
Yes, sir. Let us finish with our YouTube questionnaires. Then we will get back to you Zoom meeting. And Chandralekha is requesting our contact number. Sure, you just message me. I will give Priyank Jain sir number also. So no problem. And from Praveen Chinna, in back of neck, lymphedema is there. How can we suggest CDT? Could you explain, sir?
Back of the neck region, why there is lymphedema? There is head and neck cancer patient?
No, neck lymphedema.
Why?
Only that is one.
That's why. How he diagnosed the neck lymphedema only? What is the reason? He completed the thorough history, or there is a patient of head and neck cancer?
Okay, sir. The next is appreciation from Chandralekha, sir. Very good and detailed session. So kind of you, sir. Thanks a lot. I learned a lot, clarified many doubts. And one is from Active Care. Is by MFR also lymph nodes irritated or swelling occurs? Myofascial.
What they are
MFR,
asking?
MFR technique. Also irritates lymph nodes or swelling occurs if you do MFR technique.
We are using MFR in axillary web syndrome in post-MRM patient. If you find there is axillary web syndrome, we are using some deep tissue friction massage, but it's always depend on your assessment. Because if you find a post-MRM patient, you have to treat the full quadrant, not only the upper limb movement. You cannot get any upper limb movement if you not release the trapezius, if you not release the pectoralis major area, if you not release the serratus anterior, if you not release the latissimus dorsi, if you not release the posterior scapular muscles, rhomboids, middle trapezius. You have to clear this all area. Maybe you will use facial distortion model, or if you will use MFR. So it's depend on your assessment. And a post-MRM patient lymph node, if I'm not mistaken, you are asking about an MRM patient. Lymph node is already removed.
Yes, sir. Thank you, sir. Thank you so much. So there are so many appreciations in YouTube. No more questions from YouTube. And there is one more question in Zoom chat from Shiral Kachpai. How is the progression of congenital lymphedema?
Can you explain this question? How is the progression of congenital lymphedema?
Shiral, are you there?
So, yes, sir. So actually, this was the first patient which we saw. He was a kid, and he was admitted for some ortho condition, like some fracture, ankle fracture, and then he was getting recovered. But we noticed this congenital lymphedema which was there, and then we advised him.
That's why I will stop in the middle. That's why I told you, even they have problem in lymphatic from the birth. You will not find any lymphedema. Even a small injury, you told that there is ankle injury, it will lead to lymphedema.
Okay, but then, sir, his reports mentioned he had a congenital lymphedema. So, but then, like he didn't have any difficulty, or like his family was asking us, how will be the progression? Some doctor had advised him that after 5 years of, once he grows, like he becomes 5 years or 6 years, they might operate. So I just wanted a clear idea. How does it go? Like, how is the plan of management for this kid?
Go with CDT.
Sorry?
Go with CDT.
Okay. Yes, sir.
Nothing.
But does it?
There is no need. I think if like the kid's family will maintain a proper regime that you explain them, no need for any operation, I think.
Yes, sir. But does it help the same way it helps the secondary lymphedema, or does it take time? Or
lymphedema is lymphedema, but you don't know which area has less lymphatic or high lymphatic, and there is cluster hyperplasia but not functioning. So for that you have to go with the lymphoscintigraphy. So just start with slowly with your CDV. The kids are a little bit typical. They will not follow bandaging, so you have to go with the intermittent, like 2-3 hour Then above 2-3 hours, like colored for the custom garments, ready to wear garment, you can use with exercise in the form of play. So you have to change the treatment pattern, but the CDT is same.
Thank you, sir. And one more final question, I think, from Manali Sonavene. Hello, sir. Thank you for such a nice session. Would you like to ask what is the reference you following for volume measurement method using skin girth?
Hello, sir. Thank you. Would you like to ask?
What is the reference you follow for volume measurement method using skin girth?
We have in our hospital, we have a total full software, and we are taking only girth measurement by the measuring tape, and we are putting in our system. It is already giving the volume. We are not using that volume water displacement method. Only here we are using circumference method. In the coming month or 2 months, we will have bioimpedance and pyromotor also in our hospital.
Thank you, sir. Thank you so much for patiently explaining all the queries, actually. And I thank every participant who made more interaction in this session. And I would like to say a few words. And I never know about Dr. Priyank Jain. I was posting some of our webinars on LinkedIn, and he was constantly watching every post, and he sent a message that lymphedema awareness day is coming, so shall we do something? And immediately we made a plan, and thanks for coming forward to do this webinar. And really it was very wonderful, and many of the students have attended it, and I hope they have enjoyed, because from the basic you have taken. Hopefully. So it's not directly going into.
I tried my best that I cover as much as, but still there is huge theory or remaining part in lymphedema management. And my suggestion with every physiotherapist or student which will see my post later on, or which is still in the this webinar, is still the cancer rehabilitation and post-operative cancer physiotherapy, I think, is still not in infancy in India. So there is huge field, untouched field. So try to work in this field. Post cancer or pre-rehabilitation, there is huge scope in survivorship program, even the huge scope in lymphedema management. Even in India, I think more than 70 to 80% lymphedema case is still undiagnosed. You don't know, you are seeing the patient like post-traumatic injury, multiple bone fracture. Patient still have swelling. This is lymphedema, this is not edema. Because they damaged lymphatics. Lymphatic system is overloaded. There is decrease in transport capacity. Many times you will find the complex regional pain syndrome. You need to do the MLD. Even MLD is helping in the post TKR and THR patient also. So you have to assess the patient and treat according to your assessment.
Yes, recently even cancer rehab branch of physiotherapy is booming in India. I think if I'm not wrong, there is one college which provides MPT cancer rehab in India, I think.
I think KLE University something.
I have no idea about it. I heard about it. Hope many more colleges have the branches. So that means that physiotherapy is growing with a lot of scientific evidences. That's why we are getting a lot of branches. That's a good news. And I thank all the participants for patiently waiting and asking a lot of doubts. One may be having the doubt is not only your doubt. It may be the doubt of many people who attended it. You may have raised. So I thank everyone who made the interactive session. So once again, I take opportunity to thank Dr. Priyank Jain for a wonderful session. And also I take this opportunity to thank Professor Duna, who helped me to connect with the YouTube, all these things, and also with registrations and all those things. And certificates will be released maybe tonight or tomorrow. It will be announced either through mail or through WhatsApp message broadcasting. And thank you, everyone. Thank you, sir. Good night.
Thank you so much, sir, and EXRX India to give the opportunity to deliver my knowledge. I tried my best. Still, maybe I am unable to clear some student or some physiotherapist doubt. I will again try. If you have again, you can take my number or a mail ID from the sir. I will try my best to help you or to solve your doubt. Again, thank you, thank you so much, and stay
Bye-bye.
safe, keep healthy, wear mask, and maintain your social distance.
Nice of you. Spreading awareness. Thank you. Good night. Good night, all.